So hello everyone, welcome. I'm Ranjini Rangan from CharmHealth. If you don't know me, I write the newsletters, I do the event planning and host these webinars on a regular basis. I do marketing for CharmHealth. I thank you all for being here today. Today's event, best practices in telehealth, telemedicine, and telemonitoring during this COVID crisis. And who is DawnSelf? So Dawn is a well-respected medical billing consultant who cares about his clients and helps his clients achieve better medical outcomes and increase their practice income. He has actually helped thousands of physicians for more than 30 years, and most of them see tens of thousands of dollars increase. And he has a special guarantee, so if you end up contacting him and consulting with him, I believe he can speak a little bit more about his guarantee at the end of this session. He has given several webinars on various topics on billing, coding, and many more for highly respected organizations such as the HBMA, Healthcare Business Management Association. We are in good hands today. So I am going to now hand over the torch to you, Mr. Self.
Thank you very much. Let's get started right here. The subject we're talking about right here, telehealth, telemedicine, and telemonitoring, has been changing so rapidly. This is the most current data. I even made some changes to this particular webinar yesterday. I do not have all the answers, and again, I am updating a COVID webpage that I have. I'll show you later. On a daily basis. I am not an expert on telehealth. I'm a reimbursement consultant, and I have been helping, as she said, tens of thousands of practices. Now, the folks today that paid for the CEU is a company called RCM Health Information Management. So if you're a member of the AAPC, AMBA, PMRNC, HEMA, you will get a CEU from this if you so desire, because this has been approved. CMS has got a tough job. It's a tougher job than trying to herd cats while on the back of a horse right now. And they've been trying to get all the data to the different MACs, and the MACs are kind of lost right now, because if you go to one MAC, Novitas is saying one thing, you go to NGS, they're saying something else, Veritas saying something else, and First Coast in Florida, who knows what they're saying, because they get so much mixed up anyway. So everybody's having a rough time. So the rules I'm going over with you today are temporary. I don't know how long that this is going to happen, because we have no idea how long the public health emergency is going to last. I know in Texas, we've been opening up now for a while. California's trying to open up. Kansas was going to, then they decided today not to. So we have no idea how long this was going to last. But hopefully we're going to be able to continue to use telehealth after the PHE. I'm going to go over several things today that has been phenomenal good news that Medicare and CMS and the commercial carriers have been doing to try to make it better for everyone. But again, no one knows what the future holds other than God. And I'm sorry, I don't walk on water. My feet sink just like the rest of you. Now, some telehealth still require two-way audio video. So if somebody walks into your office and says, you can bill Medicare Part B for an office visit code because you spent time on the telephone with them, you have my permission to slap the snot out of them, because that's not true. And the AMA has confused things. In March, what they put out there, I call it that garbage they put out in March, they've totally revised. And they should have, because that was garbage back then. So just because you see something on a Facebook meme or on a LinkedIn post, that doesn't necessarily mean that it's going to apply to all carriers. Today, I'm going to go over with you how it applies on different types of carriers on some of the different kind of rules. Now, when all of this is over, there will be audits. Don't let anybody convince you that Medicare has said we're not going to be auditing, or CMS or the Department of Justice has said that they're not going to audit. They would definitely audit. In fact, I know 2 different auditors who've already gotten notifications for them to leave the end of July and August clear on their schedule, because different MACs will be using them to audit for what's going on right now. So be careful where you get your information, because they will be applying the $11,000 to $22,000 per claim civil money penalties when this is over. So again, don't believe those that say that there's not going to be. Keep a copy of everything, whether or not you do it on digital or you have to print it and put a date on it. Keep a copy on things, because again, saying I saw a meme or I saw an article by somebody is not acceptable. The racks, the Z-Picks, the bounty hunters, they all smell the blood in the water, and you know that they're going to be coming after it because those are the ones who get paid based off of the amount that they help recover for the MAC or Department of Justice or the insurance company. So let's be watching out for what we're doing today and try to keep it all above board. Now here's a little one-page sheet that I have updated at least 25 times since I started this sheet at the beginning of March, because things have been changing that much. And it's as accurate as of today. That's why I date it each time, because next week it may change. But if we're talking about a typical telehealth visit, that's an audio-video call between the provider and the patient, or the provider and the patient's family for the patient, or the caregiver for the patient who's not able to be conversive with a doctor. And Medicare, the latest rules are, and this came out at the March 30th, they want you to use the appropriate E&M code with the appropriate place of service code and the modifier 95. You might be thinking, wait a minute, I saw something that says I should use a place of service 02. Not for Medicare Part B since March 30th. They came back and said they don't want you to use place of service 02 because that puts it into a facility payment area, not the non-facility payment area. But audio video is required. I'm going to go into great detail on this. And we're going to go into detail about modifier CS as well a little bit later. Now for the telephone calls, those are going to be, you have different codes, G2012, place of service 11, but since April 6th, there's really no reason to use G2012 because on April 6th, Medicare had in the Federal Register that they're approving for payment 99441, 42, and 43 for both commercial and Medicare payments. So since they're going to be doing that, there's no reason to use G2012 any longer. I've told every one of my retainer clients stop using G2012, especially since April 30th when Medicare came out and made the payment amounts for 99441 to 43 the same as the level 2, 3, and 4 office visits. I'll go into greater detail on that, as well as the telephone call codes for the qualified non-physician healthcare providers. Those are going to be like PTs, physical therapists, speech-language pathologists, etc. I'll go into detail on that later. Then we have the portal codes for the non-physician practitioner, which is a physician, the nurse practitioner, the PA, the CNS. And then we have the portal codes for the QNPHPs. I'll go into detail. We have recorded evaluation of data, code G2010. That's the code that Medicare came out with in 2000. Well, that code's been changed several times since they came out with that code originally in 2012. But currently they're saying if you take a picture of something and send it to your doctor or your nurse practitioner or PA, this is what they can charge for looking at that picture and making a determination on it. I did this about a month and a half ago, took a picture of a growth on my chest, sent it to my dermatologist. And I told him in the text that I texted him when I sent it to him, I said, John, bill me for G2010. And he texted back and said, what is a G2010? And I told him, that's for you reviewing a picture that I sent you. He said, okay, it does look like this one needs to be biopsied. Schedule a time to come in to see me because I need to burn that off I need to biopsy it. So he did. That's what a G2010 is. You got remote physiologic monitoring. I'll go into detail on that a little bit later. And then you got the traditional tele-ICU or telehealth type codes as well. And you'll notice in all these right here, I'm giving you a place of services 11. That's if you're an office that's not owned by a hospital. If you typically bill out as a hospital-owned facility with the place of service 22, then you would use a 22 on those. So Medicare wants you to use whatever you were using. Now, whatever you heard in March, forget it. This is May, about to be June before long. So the information you learned before is probably already outdated. Information you learned 2 weeks ago is probably already outdated. That's how fast it's changing. So March 31st, they came out and said they wanted you to, for the duration of the PHE, go ahead and bill out the same way you would have prior to the COVID emergency. In other words, if you were billing out office visits, place of service 11, then that's what they want you to continue doing if that's where you typically practice medicine. If you were doing home visits only because you were a home health service or you were a home physician, visiting physician service, then they want you to continue to bill out place of service 12 with the home visit codes. That was huge. This is good news. And then on March 30th, Seema Verma, the administrator of CMS, came out and said, and by the way, that is really one smart woman. She knows her stuff. Physicians can supervise their clinical staff using virtual technologies when appropriate instead of requiring in-person presence. That was huge. That was big. Because now then, instead of the physician having to be in the same location under direct supervision, they've relaxed it. So as long as you're using virtual technologies to supervise, they're allowing it. I'm going to go into detail on that as well. Then on April 1st, CMS came out and said on an update, and if you click on the link in your PDF, you'll see where it takes you to the page where it shows you what's going to be in the Federal Register. They said on the April 6th Federal Register, on April 1st on this link, that this is what we're going to do. Code where you normally see patients. So if you're, for instance, an office-based practitioner, a nurse practitioner, a PA, and you did not go to the hospital, nursing home, or patient homes, all you did was basically you followed my advice. You kept your butt in the office. You didn't go wandering all over. And by the way, you made more money, took better care of your patients that way. Then when you're doing this with COVID emergency telehealth, you're going to bill it out as a place of service 11 and the office visit codes on everything you do, regardless of where the patient is. Patients at the office, patients at home, patients at the hospital, patients in the nursing home. You're going to build everything out with the place of service 11 with the office visit codes, because that's how you normally would have done it before when you made the patients come to the office, regardless of where the provider is. And that means that if your doctor's in the office sitting there talking to the patient on audio video, then you're going to continue doing the same way. If the doctor is sitting at home having a beer on their couch in their shorts and Bermuda shorts, then you're still going to bill it out with the place of service 11. And I'm going to go into greater detail on that one too. Let's say you had an office-based internal medicine practice, but that office-based internal medicine practice went to the hospital and went to the nursing home before, but they did not go to the patient's homes. In that case, we're following the same rules, appropriate place of service, appropriate E&M. So if the patient is at home, you're going to bill it out as a place of service 11 because you did not go to the patient's homes before. With a 95 modifier. Place of service 21 is if the patient's at the hospital and your doctor's in the office, and with the hospital visit codes 99221 through 99233. Or if the patient's in a skilled nursing facility, you're going to use place of service 31 with a 95 modifier. Now, I know that some people have a problem with the 95 modifier because they say, well, 95 says it was an interactive audio video call, but Medicare is allowing us to do some services via telephone. Should we still use a 95? Medicare says if you want to get paid, you'll use a 95. If you don't use a 95, you're committing fraud because you're telling us that the patient was in the office seeing you in person. So they definitely want you to use a 95. And I'm going to get into greater detail on the telephone call codes and whether or not you need the 95 with those in a little bit. So let's say you had a home visit physician practice. So I've got several of those that are retainer clients, and they send nurse practitioners or physician assistants or physicians to the patient's home. Everything they do is going to be place of service 12 throughout the COVID and the home visit codes with a 95 modifier. Again, that's if you're doing it with audio video. Excuse me. If you normally saw patients in the hospital doing psychiatric visits, then everything you do is going to be a place of service 21, and you'll use the hospital visit codes. Again, we're just following what Medicare has kept telling us. On April 6th, the Federal Register came out and said that we are now going to allow payment for 99441 through 43 and the 98966 to 68 codes. Again, regardless where the patient is, regardless where the provider is. So it can be the patients at home, patients in the hospital, patients in the skilled nursing facility, and the doctor is talking to them on the phone, or the nurse practitioner or the PA is, then they'll bill out these 41 through 43 codes. If it's a physical therapist, speech language pathologist, or other QNPHP, they'll bill out these codes, 98966 to 68. Again, please hold your questions to the end, and I will make sure I go through them as quickly as I can at the end right here. One of the big things they came out with on April 6th is include direct interactions between practitioners and caregivers. That was huge because Medicare understands that some patients, they may not be in a communicable mood. They cannot communicate with whoever it is on an audio video. They may be semi-comatose. They may not be, they may have cognitive issues. So if the doctor's talking to another doctor, wherever the patient is, or a home health agency nurse, or the patient's grandchild, or some other caregiver, and getting information about and sharing information about the patient, then you bill it as if they were talking to the patient. That's good news right there. OHCS, they came out in April 30th. Again, the link is up here at the top, and said they want you to bill out a G2025 CG95 if you're doing an audio video with the patient. And you're going to be paid your normal all-inclusive rate. And hospital-based all-inclusive rate might be 150, it might be 220, whatever it is. You'll be paid the normal rate, and then in July they'll recalculate it and come back and either give you additional money or take some money away to get you to the 9203 level for each one. FQHCs, they want you to use 3 levels of codes on the UB04, and you sit there and say, well, there's no room for a modifier on here. They're just saying make it a long HIPS code, a HIPS code. And they want the G0467 to 70, whichever one you normally use, and then the code showing what it was being done. Was it an office visit? If so, it might be a 99213 or 99214 with a 95 modifier. Let's say it was you were doing the Medicare annual wellness visit in your rural health, a FQHC, then they want you to use a G0439 with a 95. And then the third line shows that it was done via TeleHealth. That's how they've come out and said. Now, they may change that again tomorrow, but this is where we are today on it. And from March 1st to the end of the COVID, they're now paying the same amount on the G2025, the all-inclusive rate, for telephone calls because they don't have a mechanism at this time to pay for 99441, 42, and 43, so they're going to pay you for the same amount for the all-inclusive rate for the phone calls. So that's pretty good news right there, really good news. They finally started getting on board with this. They also started paying the portal codes. Now they're only paying the portal codes, and I'm going to go over with you in a little bit. The 99421 to 43 is being rolled into what they call the G0071 code. That's only going to pay you at $24.76, but that's $24.76 more than they were paying a month and a half ago. So this is all improvements. No COA modifier any longer until the end of the PHE, and nobody knows how long that will be. And supposedly the MACs are automatically going to reprocess all of the previous claims. Now, the MACs are sitting there saying, we're going to do what? This is another one of those that CMS is throwing things at the MACs, and the MACs are trying to keep up with. On April 30th, they came out and said for the second round of changes, for the duration of this, the CMS is going to waive restrictions on which provider type can bill for the telehealth. So that's when they opened it up for the physician assistants and the physical therapists, occupational therapists, speech language pathologists, that they can now bill out for a whole bunch of telehealth services. And I'm going to give you a list of those telehealth services in a bit. And I'm going to see if our host will be kind enough to send a link to an Excel file that has 244 codes when this is all done. So you'll get a list of the entire list of all of them. Or you can just go to the DawnSelfcom/COVID webpage and download the Excel file there, whichever way. But there's 244 codes we're going to go over with you about. This is huge also. PTs can bill for therapeutic exercises via audio video, not telephone only, but they can bill that out. That came out on April 30th, so about 20-something days ago, not too long ago. April 30th, they came out and added additional codes that can be performed. So they added E&M codes, still require, by the way, audio video, but they added 91 codes that can be done via telephone only, and they added 46 more codes to the telehealth list. I mean, this is all good news. And when you go to either the DawnSelf.com link up there or the Medicare's website, I think I'm giving you Medicare's link instead of my page, you can download on the PDF that they're going to send you this list of 244 codes, and notice the columns. You got the code, the descriptor, the status. Some of these right here is temporary only for the pandemic. Some of them are temporary and wasn't added until April 30th, and it'll say so. Some of these can be done via telephone only, and that's if it has a yes here. If it doesn't have a yes in this column, it cannot be done telephone only. It's going to require audio video. And so the list goes on, and I'm going to give you some examples here of how much this can help you. Now, I'm going to be politically incorrect for just a second. Some practices have been dumb the way they've handled the pandemic. Some have been smart. They've adapted. They've made changes. Some have been shutting down, laying off employees, furloughing employees, or trying to live off the savings, hoping this goes away. Some have tried to continue what they've always done. The smart ones right here have been the ones adapting. Now, some have had no choice. They've had to, due to their specialty or the type of services, they've had to do what they can, but others have made some poor decisions based on whatever emotions it may have been making. I have no idea, but there's been some really dumb and poor decisions on some people's cases. Primary care practices, if you're in a primary care practice such as family practice, internal medicine, geriatrics, then you've got some phenomenal opportunity right here that CMS has done. Unfortunately, many do not still realize that Medicare Part B are the most profitable of all patients they have. They believe the lie that's been told to them by the AMA or the American Osteopathic Association that you make less money on Medicare, when it's just the opposite, because a family practitioner should be making around $1,700 a year, and that's in Medicare payments, not the allowed amount. That's actual payments for Medicare Part B, if they're doing what Medicare wants you to do. Now, most do not, because most are averaging less than $300 a year. I mean, I'm doing a webinar coming up in Asheville, Tennessee, and I pulled up a list of all the docs in that area and to find out how much money they're making. Like this doctor, and these docs do not know I'm showing their information. It's all public information. All of these doctors have this number of Medicare Part B patients, and I sorted them out by the highest to the lowest. This is how much money they make in a typical year from Medicare per patient. $200, 100 and something, 130, 259. Here's a high one, 358, 405. Wow, it should be close to 1,700. If they're doing 4 visits a year, they're doing the A1C once a year, they're doing Medicare annual wellness visits, they're doing chronic care management, they're doing transitional care management. They're billing for the services they're actually doing, like signing home health certification or cognitive testing, cognitive assessment planning. I mean, they should be averaging in Medicare payments, averaging $1,700. Notice where these guys are. And most of them are doing very few Medicare annual wellness visits. Only one of the docs that are here on this list was doing any chronic care management. None of them were billing out for chronic care assessment planning, what used to be code GO505 and it's now 99483. That's about $260 for a 25 to 50-minute visit. And if you're a primary care practitioner, why are you not doing this? And Hendersonville, just south of Asheville, the same kind of numbers right here, same kind of information. This is how much money each one of these physicians, not practices, physicians have lost in a year's time. So I'm serious about working smart. TeleHealth can help you to get to that point, because a lot of the things I was just talking about can be performed via telehealth by telephone. For instance, GO438, that's an average reimbursement in the country, $177. Medicare pays 100% of it. None of it goes to the deductible. So it's not like the patient has a copay on this. Subsequent annual wellness visits. Advanced care planning was when you're discussing in the event of your death, what do you want done? Do you want to be put on a machine, etc.? Alcohol misuse screening, depression screening, all of these things can be done via telehealth. Now, the telephone calls, audio phone calls, They bumped up the payment on this right here. What was $14 to $41 is now $46 to $110 on average, bringing them in line with the other office visit codes. And Medicare is doing that again, retroactive back to March 1st. And once more, Max are sitting there saying, huh, we got to do what? Now, virtual check-in based on time. You've got to have a minimum of 5 minutes to bill out a phone call if we're going to bill it out by the provider. Now, if it's less than that, 2 minutes or 3 minutes, you might want to throw that into remote physiologic monitoring and let that build up, because that's even more profitable than phone calls, by the way. But Medicare has increased these payments right here. Now, this is again for telephone only. You have to check with every individual carrier and find out what their rules are. Some of the carriers have come back and said, for telephone only, we'll pay an E&M code. Not Medicare Part B. Definitely not Medicare Part B, but you have to check and see what the carriers are saying on that right there, because every carrier can make up their own rules. And basically, if you're wondering where Medicare said we're crosswalking these, you click down here and it takes you to the link. That's why I put all these links in here so you have the raw data. They came out on April 30th and said hospitals can bill originating site for telehealth even when the patient's located at home. I've had some people at hospitals argue with me. No, they came out and said it. Here's a link to where they said it. So if anybody argues, you have the links. The big change that took place on May 7th, again, this is this month, non-physician practitioners may provide home health services such as certification and supervision. This is a permanent change. So that's going to apply to NPs, clinical nurse specialists, and physician assistants. That's huge. So they get to bill the GO179, GO180, GO181. Now, you sit there and say, is that a big deal? Yeah, keeping in mind that most doctors that I've talked to, and I asked them, why have you been not billing for the GO179 and GO180? They didn't know they could because somebody in the billing staff did not tell them they could. So we need to make sure that doctors know they can bill for these things, as now can the NPs and PAs. PT and OT assistants can now do the services that would have been before COVID allowed only by the physical therapist or occupational therapist. So again, that's following the rules. Incident 2 has been relaxed. They did this right here on April 6th. They came back and said that on April 6th. And again, we have our link right here to where it goes into detail on page 188. A physician or practitioner can oversee or basically give supervision. What used to be direct supervision can now be under general supervision if the physician or the supervising provider is available via some kind of an audio video. That doesn't mean they have to be on an audio video like we're on right now, but they have to be available if the employee in the office has to say, hey, doc, jump on an audio video call with me on my cell phone so that way I can ask you a question. If they can do that, then you can then bill it out as if the physician was in the same suite at the same time, given direct supervision. 99211. On May 14th, Medicare came out and said that nurses, MAs, pharmacists, whomever, that could do a 99211 before the COVID can now do a 99211 via telehealth. They said that 34 minutes into the call, and if anybody asks you where's the proof, you can click right here. It takes you to CMS's website. Fast forward into 34 minutes in there, and this is exactly what they said. Again, great news. I'm just full of great news. One thing after another, they keep telling us all this. The home can now be the originating site now during the emergency. Again, that changed back in March. That's effective dated back to March 6th, but that changed at the end of March. Telehealth is no longer just for the doctor being in the office. The doctor can be at home sitting on her couch doing an audio video with a patient, and you bill it out just as if the doctor was at the office. You do not have to go back into PACUS and change it or the 855. CMS has said that telehealth is now for not just Medicare Part Advantage, Part C, but it's also for Medicare Part B, Medicare Part A. Any of the patients can be Medicare. Any Medicare now can be using telehealth, where before it was only for Medicare Advantage. Rural health requirements have changed. So if you're in Oakland, California, you're in Los Angeles, or you're in Baltimore, Maryland, or wherever, it doesn't matter. you can still be doing telehealth. It's not for rural patients only anymore. So we have to use the appropriate codes. When it talks about initiated by patient, it means that you didn't surprise the patient with this right here. It's going to pay the normal amount, and it does require audio video if you're going to be doing E&M codes. For the temporary, you have a temporary waiver. The 1135 waiver gives us permission to be able to use FaceTime, Skype, Zoom, most of the different kind of medias. You can't use Facebook messaging or Facebook video because that's a public forum and there is no protection at all on that. But you can use Doxy and the others. So now, also new or established patients. I had a doctor ask me yesterday, how can I be allowed a new patient visit if there's no exam? Well, the exam requirement's no longer there for telehealth. I'm going to go into detail on that. So it's new or established patients, Medicare says. Use a modifier 95, even if you have a certified professional coder who says modifier 95, according to the rules, and the CPT Coding Commission says it's only for the audio video with interactive means. So you cannot use a telephone call with the modifier 95. Well, I'm a certified coder also. I'm telling you, you can. Because Medicare makes their own rules, and they say they thumb their nose at the AMA and the CPT. They do that on many, many things. There's a whole bunch of rules out there that have one rule for Medicare, one rule for everybody else. This is one of those. Now, commercial carriers might want a GT, GQ, and 95 modifier. This is big right here. This is huge, and I can't believe how many people have totally missed this one. If it's being done via telehealth, you can base your E&M on the medical decision-making or time alone. No more history exam medical decision-making the way you normally have right now with an office visit in person. And it still requires, office visit in person still requires history exam medical decision-making. But if it is a telehealth, you can go with time or medical decision-making only. And with Medicare, you have one set of rules. You have threshold time. And the only one that requires start and stop time, as far as I know, is prolonged service codes, unless you're talking anesthesia. They require start and stop time. Commercial insurance, though, says nearest amount of time. So, and again, same thing with commercial carriers. The only time they require start and stop time is prolonged service codes. So let's talk about time. On April 6th, the Federal Register said that we're going to give you a new set of times, and they gave you a link for a download. On April 14th, the CMS office hours call said use either CPT book time or the time we gave you in the chart. On May 8th, CMS office hours call said use CPT times only, which makes sense because nobody wanted to use the times that was in their chart because it was longer. You would lose money. So here are the times we're talking about. The same times that we've been using since 1996. 10-minute visit, 99201, 20-minute visit, etc. But here's a little tip for you right here. Medical decision making will almost always give you a higher level of service than time will. So if you're doing a medical decision making of moderate complexity, but you only spent 10 minutes with a visit, you get to go with a higher code. There's nothing that says that time will drag you down. So here's an example right here. Let's say you do an office visit in person. You still have history, exam, medical decision making. 2 of 3 for established, all 3 for a new patient. We've had that since 1997. But if it is a telehealth visit, all we have is the MDM or time. So at my 15-minute visit, 99213, or if the MDM is higher, we can go with, even if it's a high level MDM, and you only spent 15 minutes, that would be a 99215. Medical decision making alone can make the decision, and again, it can give you a different code and a higher code. Home visits, you've got 3 codes for the established patient home visit code. So a 25-minute visit would be a 99348 unless the medical decision making gave you 99349, in which case you'd go with a 99349. A lot of people get confused, especially providers, on medical decision making. I've got a little free 10-minute webinar. It's on my website. I've also got it on YouTube right here. And you click on that, and it goes through all the different points and bullets and how easy it is for a provider, doctor, nurse practitioner, PA, to be able to document the higher levels of medical decision making based off of the amount of prescriptions, rule out diagnoses, and I love rule outs, by the way, from a documentation standpoint. Doesn't go on a claim form, but the rule outs give you higher levels. Management options, number of diagnoses, the data being reviewed, risk of complications, and it's real simple, little 10-minute webinar. Check it out at your convenience right here. Now, let's say your office calls the patient to remind them of the appointment, and you give the patient a choice. Do you want to come in? If so, we're going to do the temperature on you before you come in. We're going to make you fill out a little questionnaire before you come into the door. We're going to check you out right here. Or would you rather do a telehealth visit? Because if so, we'd be glad to do telehealth. Patient chooses telehealth, so then on the day of the time of the appointment, the doctor calls the patient, or the MA calls the patient, gets them all established, and then the doctor comes in. Now keep in mind, if it's a telephone call or an E&M based off of telehealth, according to the April 6th Federal Register, you get to count pre-time. The time the doctor spends reviewing the chart prior to the call, the time on the call with the patient, conversing like we are here, and the time the doctor spends documenting after the call. That all gets counted. That's what was in the April 6th Federal Register, and that's huge. Will that continue after the PHE is over? I hope so. I don't know, but I hope so. I really do, because this is what counts. I mean, this is the time the doctor is spending on the patient care, so that's cool. By the way, this kind of a visit, that's patient initiated, even though the patient wasn't the one that dialed the phone or connected via Skype or Zoom with the doctor. The doctor initiated it. This is still considered to be patient initiated. Now, let me warn you, don't call patients and scare them and require they do a telehealth, et cetera, because there's going to be a lot of ethics violations that's going to be prosecuted when this is over. I've already seen some lawsuits starting in Illinois because doctors and others, staff members of doctors, were trying to push the patients into doing telehealth. CS modifier, a lot of questions about that one. When Medicare first came out with that, they said, if you are evaluating an individual for purposes of determining the need for such a test, you can use a CS modifier, and Medicare will pay 100% on the visit, on the E&M code, whether or not it's done by telehealth or in person. Well, they then came back and said, no, we're going to change that because of the word "and" is in here. So it has to have an administration of or an order for a COVID test. Now, regardless if it's a finger stick, the COVID antibody test, or whether or not you're sticking a Q-tip that's, not 24 inches long, Q-tip up their nose and down to their belly button. However you're doing it, that is a test. So that means you throw a CS modifier on there, but only if this visit is related to the ordering or going over the results of the test or the evaluation of the individual for determining the need of the test. Once they have COVID, we don't keep throwing CS on there unless we're going over the results of the test and now we're telling them. Consent. Office visit codes do not have a special consent requirement on this. I've seen some folks trying to come out, you've got to have the patient sign something. No, you don't. Not if it's an office visit code. If it's a telephone call, you're required to have consent, but Medicare said verbal consent during the call is okay. They said that on April 1st, April 6th, and again May 8th. So we've got plenty of documentation on it. But my advice is have a witness on the call with the patient, with a doctor, a nurse practitioner, a PA that you're doing, and say, patient consented to call. Okay, doc, here's your call. And that way you have somebody else saying that it was consented, not just a provider. Now, every carrier is making up their own rules, and some are requiring different modifiers. Some are waiving copays. Sometimes when they waive copays, that does not mean they're paying a penny more. They're telling a doctor to take it in insurance. Other times it means that they're paying 100% rather than the patient having to pay anything. Some Part C plans are paying for E&M visits for phone calls. So you have to check and find out, what does Anthem Medicare, what does United Healthcare Medicare, Humana Medicare want? So you got to go to each one. One office manager gave me this sheet. I said, this is really cool. But again, the following day, the day after she gave me, Medicare came out and changed things. And I said, your sheet's already outdated. So it's like Chandler on the Friends TV show. Can you make this more confusing? It seems like they're trying to do that. So when I was talking about virtual check-in, telephone call only, and I know most of you have never seen a phone like this unless you're my age, and then that's all you've ever had. But just a telephone call by the occupational therapist, the PT, the certified nurse anesthetist. I don't know about chiropractors because Medicare has still not clarified that. 5 to 10, 11 to 20, 21 to 30. They did not increase the payment rates for these, so they're still going to be running somewhere between $14 to $41 on these things right here. But that's still $14 to $41 that we're now getting that we weren't before. Check with each carrier, find out what their rules are. Make sure it's not related to a previous assessment that occurred in the previous 7 days. So if it was related to a previous assessment, we can't bill it. But how do you tell Medicare this was not related? Do they want a 24 modifier saying unrelated E&M? This isn't really an E&M. Do they want a 79 modifier saying unrelated procedure? Medicare, you have to check with your individual MAC. I know in Florida, Medicare, they said that they wanted a 79. Novitas in Texas said they wanted a 24 modifier to show it was unrelated. But you got to check with every carrier because they're going to make up their own set of rules. And again, this cannot trigger an office visit within the next 24 hours of the first one available. Now, when I'm talking about a portal, let me explain what I mean by that. In Tyler, Texas, we have several of our hospitals, Christus Health Systems, use MyChart. So I can log into MyChart and I'll give them my username and password. Maybe it's Red John. Those of you that ever watched The Mentalist will get a kick out of that. But to send a message to my doctor, or I want a prescription refill on my metatoprol or my nitroglycerin or whatever. I want to pay my bill. I want to schedule an appointment. I want to assess my last test results. That's what we're talking about, a portal. So when we're talking portal codes, 99421, 2122, and 23, which Medicare pays decently for the doctor spending a little bit of time. Not as much as they should, really, because they're undervaluing the doc's time, since this is for a physician, nurse practitioner, PA, a certified nurse midwife. When they're talking about this right here, this is not just the patient picking up a cell phone and texting the doctor, and the doctor texting the patient back. This is going through the portal in order to bill out these codes. And the portal is something that the patient has to enter in a name and a password, a username and a password on. And they must consent to using virtual check-in. So whenever they log into the portal, you should have in your portal, patient consents to use this during the COVID crisis. Now then, we're now covered on that. Now, you have for the qualified non-physician healthcare professionals, you've got different ones, and their reimbursements are less. But this is, again, portal codes up to 7 days of cumulative. So let's say I sent a message to my physical therapist 2 days ago and said, I've been having trouble with my knee since I had a knee replacement. And so they read it, and then they check, and they send a message to me. And today I send another message. And they need to accumulate all of this time in the 7 days to come up with which one of these codes, because it's a cumulative 7-day period. Specimen collection. Medicare came out with the G2023, was paying around $24 nationwide, and that's for sticking the swab down the throat or doing the finger stick. The swab down the nostril, doing the finger stick. And doctors' offices that were opening up testing stations and having to dude up their employees and all the PPE with the mask and the helmet and the gloves and the long sleeves and everything. They were sitting there saying, we can't live on a $3 venipuncture. You don't even do a finger stick payment. Medicare doesn't pay for 36416, although most commercial carriers do. So what can we do? So Medicare came out and said, instead of just a G2023, they're now going to allow you to bill out a 99211. And that's where they came back and said this right here. It's basically a level 1 E&M visit. And this can be done outside. This can be done by the hospital. This can be done in the parking lot or the doctor's offices. Now the question comes up, can we bill a 99211 and an office visit on the same day? That question, CMS is still not addressed in their CMS office hours. I've been watching that, but they still haven't told us. On April 1st, they came out and said that OIPM services, remote physiologic monitoring, can now be furnished to new patients as well as established patients or for acute or chronic conditions. This is huge. When Medicare said they're going to cover this in January of last year, I created a company very quickly and provide monitors to doctors from around the country. And whether or not we're talking about a blood pressure, a glucose, pulse oximeter, or blood pressure for a patient who does not have a smartphone. So we have one particular monitor that works off of SIM card technologies. It's got a SIM card built into it. Medicare loves this, by the way, especially during the COVID. And this is why, because throughout a 3-year study that Medicare did from 2016 to 19, they saw some huge reductions in hospital admits, hospital readmits, and ER visits. So Medicare started paying for 3 codes last year, and they pay for 4 codes this year. And it may seem, well, it's not very much, but it does add up. I've got a few of my clients, it's pretty much doubled their practice income right now by using telemonitoring. So it does add up, whether or not we're talking blood glucose, blood pressure, temperature, weight, or during the COVID, a lot of practitioners are sending home a pulse oximeter and a thermometer. So instead of sending the patient to the hospital, they say, take this at home and take your numbers every 2 hours or 4 hours. And my staff's going to call you 3 times a day. And when we call you, we're going to ask you what your temperature is. We already know what your pulse oximeter numbers are, so we know how much oxygen you have, because every time you put your finger in there and it does the test, it transmits the data to us. So my staff's going to call you 3 times a day and spend about 3 minutes on each one. That's about 135 minutes in a month. So that's about 135 minutes in 2-week period. That's about 396 Medicare allowed. So even if the doctor's paying for the system on a monthly rental basis and paying a nurse a bonus for making calls at 7 in the morning at 9 at night, the practice still increasing their practice profit about $200 net profit a month. And that's per patient. And that keeps the patients out of the hospital, away from the pathogens at the hospital. Now, if you ever watch that TV show House, Gregory House said patients lie. And I've seen patients lying on their blood pressure numbers. So let's say you send home a blood pressure meter. Medicare, again, loves this because it's saving them a lot of money. And the staff logs in and checks the numbers 1 minute a day for 20 minutes a month, which is 20 days a month. For most offices work 22 working days a month. Then that's still not bad income. And if you're making an extra $71 a month, that's about $859 a year. Remember all those family physicians I showed you in Asheville and Henderson that were averaging $200, $300 a year per patient? This is tripling their income. Or if they're glucose monitoring, it's still almost tripling their income, because glucose monitors end up costing more because you got to provide the strips and stuff to the patient. So if you need more information on that, visit Telecare USA or send me an email. Now, folks, DawnSelf.com/COVID. The web page is being updated almost every single day, and it has all of the reports that I've given you in here from the Federal Register. It has the 244 codes. It has the Federal Register itself. It has the updates Medicare has been publishing, as well as my advice on it. It's got links to commercial carrier policies on there. So if you're wondering, does United Healthcare pay for this and what code do they want? You can find it on this page, because people like you are updating it to me, which I'm putting it on there. It has the documentation template on there. And everything on that page is free, by the way, including this webinar, if you ever want to watch it again, or if you have somebody else you wanted to have watch it. It's got downloadable documents like the template, etc. Now, if you're not doing chronic care management, now is more important than ever, and it's really easy to do. If you don't want to do it yourself because you don't want to provide live clinical coverage 24/7 that Medicare requires, I've got different companies I deal with. One of those is Shortspan. I just love that company. But you don't have to use Shortspan. You can use another company, because Medicare came out in 2015 in May and said you can do pass-through billing on chronic care management. So if you're going to be doing it, if you're not doing it, you really should. If you ever want me to, you can click on my link on my webpage and say, I'm going to lock in an hour's time with Dawn, and I'll spend an hour. I'll pull up your best billing history, and if you don't send it to me, I'll pull it off of Medicare's website that I already have on every provider in the country. And I'm going to ask you questions and make recommendations. If at the end of that call, I'm going to ask you one question, and that is, did this call just help you increase your income by $20,000 a year? If you say yes, you'll pay me my $500 consulting fee for that hour we just spent. If you say no, you don't owe me a penny. So you're going to make at least $20,000. The family physicians normally average between 120 and 130,000 a year increase from that 1 hour. Internal medicines is usually around 90,000. So it depends on your own practice how well you're doing. So let's see what kind of questions you have right here, and I'm going to open it up for questions. So, what if your billing modifiers are wrong since we missed the updates? I don't know. If you're sitting there saying, were you using a GT modifier instead of 95, Medicare is going to deny the claim. If you're using the O2 place of service, they're going to pay you at the facility rate rather than the non-facility rate, so you'd need to submit in a corrected claim on that. Terry asked, is the MDM and time only versus needing history exec requirement temporary? Yes, it is for right now. Now, Terry, the good news is next January 1st, CMS has already got this set in stone, regardless of whatever happens with COVID or the emergency right now, regardless of that, they're going to time a MDM only next January 1st. And that's really huge, especially for primary care. This is great news, especially if you teach your doctor anything about MDM, even if your doctor is only moderately good at documenting MDM, then it's still going to be a big increase, and they don't have to worry about history and exam, review of systems, history of present illness, past family social history, as far as picking the code. Now, let me clarify something. Your doc still should document the history and exam, because the reason for that is if you don't, your medical malpractice carriers are going to go pee-pee all over themselves. So for patient care, you really want to document that. For code selection, all I have to look at as an auditor is MDM or sound. Dr. M, how do we code for the new edition of reimbursement for documenting time, longer E&M codes? Okay. When we're talking about new edition for reimbursement, if we're talking about telehealth, you have the 99358 code, which is about, I think that's average about $132 in the country for that code. And that's for non-face-to-face interaction with the patient, prolonged service. And so how would you build that out? That would be like if you did an hour on the telephone with a patient. Then you might have 99443, which is for 21 to 30 minutes, then a 99358 for 30 to 60 minutes prolonged. So you'd have both of those. So you're going to end up around $200 for that hour. Thank you for such a great presentation. I'm a cash-based practice where I provide itemized receipts, and I've continued to use simple office visit codes for new and follow-up visits, also entering the time we spend with patient. But my assistant types in video visit or phone visit on the receipt. I'm glad they are. I like your assistant, by the way. Some patients submit these receipts to their insurance carrier for reimbursement. Should we be going back to all visit receipts since shelter in place started to change and improve the coding we've done? Yes, I think you really should. I like going back to the making sure you include that on there, because your patients have no idea what code to put on there. So train your assistant whether the audio video is going to be an E&M code and the audio only is going to be an E&M code. I mean, the 99441, 42, or 43 code, and that'll help your cash patients get reimbursed from the insurance carrier. Great question. Also, when doing E&M with audio visual, do you have a template for the documentation you have in physicians? Yes, it's on my website, DawnSelfcom/COVID. It's a template for that purpose, and you're welcome to take it, change it, and use it. I'm not charging you for it. Help yourself. What if my billing person made a mistake that needs corrected? Instead of 95 modifier, it went in as 95 visits, and CMS paid the claim, behavioral health. 95 number of units? Wow. Okay. You got paid 95 visits, and for one visit, yeah, you definitely need to do a correction with them, but I don't send them money automatically. Contact the Medicare accounts overpayment department and say, we screwed up, help me correct this, because you want to notify them before they notify you. And they'll walk you through how to submit in corrected claim and then how you give them the money. But don't give them the money until they ask for it, because otherwise it'll go into a different department. Later they audit you, and then you end up having to pay it twice. So what would the code be then for pre and post telemed patient prep, lab reviews? Okay. you're going to be having a audio video call with the patient. You're reviewing it, so the code gets counted into the E&M visit or the telephone visit, but your documentation needs to show spent 3 minutes pre-visit reviewing labs or 5-minute post-visit documenting. And then you'll bill it out for the E&M or the 99441, 42, or 43 code. And by the way, the 99441, 42, and 43 code are classified as E&M codes. They're telephone E&M codes under HCPCS coding. So follow-up for E&M code 99358. Do we need a modifier on the E&M? No, 99358 is an add-on code, so no modifier needed. I read with the COVID there are ways for people who have not billed Medicare before to now start billing much easier than before. Can you explain what steps to start the bill? I have no idea. I hadn't read that. You've got to get, first off, you got to get an 855 or a PACUS form submitted into Medicare. They got to do the check on you. That's probably going to take, I think, typically about 60 days to get a Medicare provider number. So, Edward, if all you've been doing is cash and now you're wanting to start doing Medicare, or you've had you sent a letter to the Secretary of Health and Human Services saying that you opted out, I really don't know how you'll get back in really quickly and easily. I'm sorry. Do we need to correct the place of service if many of my claims went in as O2 as they first told us and we missed a deadline to make the change? Okay, let's talk about deadline to make a change. How long do you have to submit a corrected claim? You have 1 year to submit in a corrected claim right here. So anonymous attendee, I would submit them back in as a corrected claim according to the protocols of your own MAC. Now, yeah, that's definitely what I would do, because it's your money, and there's probably about a 37% difference from what they paid on an O2, because if you have an office place of service 11, they were paying you as a place of service 22, which has about a 37% reduction in payment.
Thank you so much, all of you, for your questions. I'm sure many others had the same questions, so that helps clarifying. Thank you, Dawn, for answering with a lot of clarity. I appreciate it. And all of you who needed to ask some of those questions directly to Dawn. Dawn, if you can just say your email one more time.
It's DawnSelf@DawnSelf.com. I'm not nearly as egotistical as that sounds. It's just I want people to find me.
Yeah. I think it's really, really simple to find. Exactly. I can say it in my sleep. So yeah, that's great. It was a fascinating webinar with so much information. I hope this webinar clarified a lot of these questions for our practices. I think no area has been as transformative in healthcare, or no time has been as transformative, I think, in my lifetime at least. And I look forward.
Amen.
Yeah, I look forward to seeing.
May I make a couple of suggestions? Because someone asked a question, how do you get more information about telemonitoring? Now, this is going to sound very self-serving, but send an email to DawnSelf@DawnSelf.com. I will reply and give you a link that you can then pick a date and time from, and we'll go through and I'll take a look at some of your patient volume and insurance mix to find out if telemonitoring will help you. I've been adding on an average of 2 new telemonitoring clients a week. Literally, this has been huge for me going on right now.
All right, wonderful. If there are no more questions, I want to thank you all for coming to this webinar. It's been really wonderful, Dawn, to have you here and enlighten us on this very, very detailed and intense subject that is constantly changing. So, thank you all. Thank you all to all of our attendees for being here as well. We look forward to seeing you for the future webinars as well. And let us know if you have any requests for other webinars. I'm here to serve you and your needs. CharmHealth is here for that. Have a wonderful day and stay safe.